And welcome back to Urban Outlook. The National Academies of Sciences, Engineering, and Medicine says the U.S. transplant system needs a complete overhaul, that the current system is wasting organs and not giving enough patients a fair chance at life-saving transplant surgeries. A recent JAMA report has similar findings. It says that providers' decision-making must be addressed because black and female heart failure patients need an equal chance of survival by getting heart-assisting implants that could save their lives. Meharry Medical College is aware of these and other issues with health care. Meharry is partnering with Tennessee's Organ Donation Agency and making doing some things to combat disparities among transplant recipients and increasing the number of black Americans registered as organ donors. Joining me today to share more about those efforts, Dr. Carlton Adams, the chair of the Department of Surgery at Meharry Medical College, and Dr. Marty Sellers, who is the organ recovery surgeon at Tennessee Donor Services. Thank you both for being with us today.
Thank you for having me.
Thank you.
Well, this is a brand new initiative, one that was announced recently, that Meharry, that your agency, and a number of other historically black medical schools are going to try to figure out ways to fix the disparities that exist in the transplant system. Talk just a little bit about this initiative and how it came about.
Well, as I understand it, the national leaders in historically black colleges, medical schools, our leader, Dr. James Hildreth, met with the Tennessee Donor Services and other national donor services and transplant leaders about how we could actually increase the number of transplant recipients, awareness about transplantation, and the science that could be directed towards disparaged populations.
And what exists right now when you look at the whole transplant system? We've got the U.S. saying, U.S. agencies saying that it's broken, something's wrong, there's not a fair distribution of organs to people who need those organs. What are you seeing when you look at the state of this situation at this point?
Well, the report that you alluded to, the NASM, National Academies of Science, Engineering, and Medicine, adequately or certainly exposes the fact that inequities exist. I think it's important to note that a lot of good work is being done, but there are shortcomings that are demonstrable, and I think they are disproportionately shortcomings of the communities of color. The things that are being done about that, and where Dr. Adams' world and my world overlap, is specifically with respect to kidney disease, and that is one component of a larger health system where disparities exist, but certainly with kidney disease, disparities with access to transplant for the African American community are demonstrable, and I think could be fixed with an improved awareness of the value of transplant. The African American recipient is more likely to be a genetic match for an African American donor, so part of the initiative is to increase the number of African Americans that are willing to sign up to be organ donors. That will increase the likelihood that an African American on the waiting list will get access to kidneys. The biggest disparity, I think, though, is, as I mentioned, access to the waiting list. Once someone gets on the waiting list, the African American population is 13% or so of the U.S. general population. About 30% of the population on the waiting list is African American.
Dr. Sellers, what causes that breakdown, though? What happens that the names of people of color don't make it to the waiting list as regularly as their white counterparts?
That is upstream from the transplant component.
Okay.
The whole report, the NASM report that you alluded to, encompasses the entire system of transplant, meaning the development of organ failure and getting access to the waiting list.
Mm-hmm.
Once you get on the waiting list, the likelihood of getting a transplant is the same if you're African American versus Caucasian. It's the access to the waiting list that is, I think, rooted in a lot of the things that are similar to other components of the healthcare system in terms of lack of access, socioeconomic issues, some mistrust in the system, or some, suboptimal trust, maybe a better term, in the system. But the awareness that there is something that is better for me than dialysis is lacking, and I think that is one of the things that we need to do a better job of, not just educating the public on, but even within the physician community, there's a lack of awareness of the benefits of transplant compared to dialysis.
I know in some areas of the country there's an issue with the hospitals that may not provide the service, right? So you would have to go outside of your state in order to get transplant services. But here in Tennessee, that's not the case, is it? We have hospitals, we have physicians like yourselves who are capable and able to do those kinds of surgeries, right?
Correct. And there's many well-known facilities in Tennessee, and certainly adjacent to the state for which people can select. And when we talk about different types of transplants, kidney transplantation is a population of people who are qualified by their end-stage renal disease to have insurance coverages. But it's still a selection. And in some cases, individuals may perceive it as an end-of-life treatment rather than an extension and miracle of life, because it is one of the choices for end-stage renal disease management. And it's probably something, when we talk about their choices, even when we mention transplantation, it should be a continuous conversation with their providers.
Say that again, that people sometimes feel that a transplant is an end-of-life decision.
Fear that it's an end-of-life decision.
But it prolongs life. It saves lives, doesn't it?
And so does the dialysis treatment that they are currently on.
Okay.
It's one of those things that, as I think about it, it also puts them in a community of people with the same illness, so they're not isolated. And as they think of who they know who has dialysis, end-stage renal disease, they can think of several family members and friends. But as they think of who has had a transplant, and it's hard for them to recall that, even just the conversations about it.
That's really interesting, because I thought of dialysis as the treatment to keep me healthy until the transplant happens. But that's not necessarily the case with all the patients that you see, huh?
That's the best use of dialysis. The average survival on dialysis is about 5 years. Or maybe the better way to, the median survival, meaning about 50% of the patients that get put on dialysis survive for 5 years. That is far better than no other option, but when you consider transplant is an option, the life expectancy is much, much better. More than half of the patients that get transplanted with a kidney live more than 10 years. So it's dialysis is life-saving because it keeps you from dying of kidney failure now, but it doesn't prevent you from all the ravages of dialysis. And the way I look at dialysis and the way I explained it to patients when I was doing the transplant side was, your clock is ticking faster. You're aging faster when you're on dialysis, meaning you're going to get to the end of your rope or the end of your life sooner. You can slow that process down by getting a kidney transplant. And we've talked a lot about kidney transplants, and in Tennessee, 3,000 people are on the waiting list for a transplant. 90% of that waiting list is comprised of patients that are waiting for a kidney transplant. There are other organs obviously being transplanted. The biggest burden to the system in terms of need for organ donors is the person on the kidney waiting list, and the decisions that we make every day are basically driven by what we look through the eyes of someone on the waiting list. What can you do to get me off dialysis, or get me out of the ICU with liver failure, or get me a heart transplant for my heart failure? We make our decisions, and our policies are driven towards that end, with also doing the best we can to respect the donor and the donor family and their decision to have donated, and to give them the best chance that they're going to leave a legacy of a functioning transplant is, functioning organ, heart, liver, kidney, into the recipient for as long as possible. So it's somewhat our responsibility to honor that wish and give them the give the family the peace of mind knowing that they did something that actually is going to prolong someone else's life.
The partnership that you all have not only focuses on making sure that you sort of combat the disparities that exist and make sure that there's fairness and making sure people of color end up on these transplant lists, but it also focuses on making sure that African Americans become donors and all people become organ donors. Talk a little bit about that side of the program.
Well, for sure, one of the things we want to do is make sure our students and our educators become fully aware of this project and the aspects and benefits of transplantation. So one of the things we're going to work together on is a training program for our students and for our faculty, where Dr. Hildreth is also set about and determined to increase the gene pool information about African Americans. So we want to get individuals committed more towards tissue donation for eligibility, even if they don't agree to be eligible to donate their tissues through operation time frames when they're having elective procedures, so that we can actually expand the gene pool so that there can be individuals who are eligible get better matching of organs.
There's still that fear that exists, though, to be an organ donor in our culture, for sure.
Absolutely, and fear can drive you into decisions that aren't rooted in sound information. Mm-hmm. And so recognizing that, we have to have more individuals and more programs, and we have to coordinate programs that address those fears. We need our primary care physicians to be actively talking about that with their patients, because when they do talk about that with families and patients, then they get into the conversation and can provide some comfort and some correction of what they may think could happen. That builds a trust that allows them to get into the system and encourage their neighbors to also consider it.
We've got just a couple of minutes left in the show. What role do patients have in making sure they ask the right questions, that they demand the right kind of treatment that they need? What's the role of patients in all of this?
I always told patients that the best question to ask is, what did I not ask that I need to know? And I think that's particularly true with kidney failure and with kidney transplantation. The things that, as Dr. Adams alluded to, there's a fear that we need to eliminate. Transplant is much better in terms of quality of life. It's much better in terms of life expectancy. So there's never a risk-free operation, but considering the benefit, this is one of the best risk-benefit analyses that favor taking the risk of surgery.
And if people want to know more about this initiative and the partnership that you have, where can they get more information, I guess is where I'm going with that.
We would say that they first start with their
old primary care physician.
Doctor.
Mm-hmm.
But they can always reach out to Meharry's Public Relations Department or Tennessee Donor Services, mm-hmm. and they could just dial that up on their Siri or Google, and they will get directed to the appropriate persons. Or you can call us directly. We're available, both of us, through telephone resources.
Research is key for sure, so if you need that information, make sure you reach out to these two docs for sure.
I do think it's important to say that the relationship that we're developing is just that. Right now we're in the very early stages of it. We don't have the details worked out, but we recognize the potential and the gravity of the situation, and because of that, the conversation that Dr. Hildreth and Jill Grindis, my CEO, had that got this off the ground, the potential, it's an awesome opportunity, and it's one that we just can't afford to fail.
Powerful, powerful opportunity here. Thank you all both so much for joining us, and thank you for joining us as well. We'll see you again next time.